Good morning. How's everyone doing this morning? Everyone get enough caffeine and everything? So good. Well, it's so glad to be here, and I really am honored to be here to sort of be the MC or whatever of our third annual symposium and combined collaboratory event. So what a treat to be able to do this in combination with the Learning Health Systems Laboratory here at University of Michigan. So mainly I'm here, I'm Amy Kilbourne if you don't know me, and I'm the lead of the Implementation Dissemination Core for Michigan's CTSI, the MISHRE program. Basically, I want to first actually offer a quick thank you to the people who make this event happen. And I'm talking about particularly, we'll go through all the faculty, of course, but really the staff at MISHRE and DLHS. So I just want to give a shout out to Veronica, Eli, Noor, Johanna, and Beth, and others who've really made this happen. Without them, we wouldn't be here. So just want to give a quick shout out there. So thank you, yeah. And of course, I also want to thank our sponsors, the Michigan Institute for Clinical and Health Research, MISHRE, and also our Department of Learning Health Sciences and the Institute for Healthcare Policy and Innovation. And I think that trifecta has been a wonderful combination of collaborations and opportunities for many of you. Today's session is recorded. It will be available on the Learning Health Science and MISHRE YouTube channels. And you can submit questions for the keynote presentations and the panel and fireside chat. We have a lot going on today. So you have lots of opportunities to ask questions using the QR code at your tables and a link in the chat. Also, we have CME credits available for this event as well. And so we will have a brief break in between the keynote presentations and lunch at noon. So do stick around for that as well. That's a wonderful opportunity to network. So at this time, I get the opportunity to introduce our director of MISHRE, Dr. Julie Lumeng. She is the executive director of the Michigan Institute for Clinical and Health Research and associate dean for Research in Clinical and Translational and associate vice president for research at the Office of Research. She is also the Thomas Borders Family Research Professor of Child Behavior and Development and a professor of pediatrics for the medical school and professor of nutritional sciences at the School of Public Health. So I'll have Julie right now just give some introductory remarks. Thank you.
So good morning, everyone. And Amy, thank you so much for that introduction. And again, Amy leads our Dissemination and Implementation Science Core at MISHRE and has just done a superb job with that in the last 4 years. It's one of the key areas of focus that the NIH wants MISHRE, the CTSAs, to be allocating their resources to. And so we are very grateful to our partnership with DLHS and with Amy for making that happen. So I want to welcome you to the Symposium on Implementation Science and Learning Health Systems. We're so pleased to have you join us today for what promises to be a thought-provoking and impactful event. This symposium provides us a unique opportunity to engage and hear from renowned experts in implementation science and learning health systems. I'm looking forward to today's talks and discussions and expect to hear both familiar and new ideas about the challenges and opportunities that we face in our work. The symposium is again sponsored by MISHRE, the Michigan Institute for Clinical and Health Research, which is funded by NIH as our CTSA here at the University of Michigan, as well as the Learning Health Sciences Collaboratory and the Institute for Healthcare Policy and Innovation, or IHPI. MISHRE aims to be at the forefront of clinical and translational science by pursuing opportunities to understand and address the challenges inhibiting the growth of learning health systems. Achieving this goal requires MISHRE to develop tight partnerships that span U of M's health research and provider communities. For these many reasons, I'm grateful for this opportunity to collaborate with the LHS Collaboratory and IHPI to organize today's symposium. At the heart of our shared purpose today is the commitment to accelerate the journey from scientific discovery to real-world impact, both here at U of M and across the state of Michigan and beyond. The promise of learning health systems depends on our ability to translate this commitment into action to help narrow the distance between research and practice. Despite the rapid pace of research and innovation, it still takes up to 20 years for just 1/5 of scientific discoveries to reach the patients who could benefit the most. We can accelerate progress to this goal by ensuring that proven effective treatments and practices are adopted in clinics and hospitals and reach those who need them as quickly and effectively as possible. The implementation of the latest evidence-based practices in clinics and the advancement of translational science in academic medical centers doesn't happen in a vacuum. They both happen within systems. We all want to see providers and healthcare teams empowered to use evidence-based practices and treatments so that their patients benefit sooner and more consistently. That's why learning health systems are so crucial. They leverage scientific methods and patient data to align the needs of patients and providers with advancement of clinical and translational research so that our clinics have increasing capacity to provide patients with the most effective and needed treatment. Today's symposium is an opportunity to engage, learn, and collaborate with one another. We'll hear from experts in implementation science, quality improvement, and learning health systems. Our discussions will touch on new innovations, pressing challenges, and real-world solutions to accelerate the uptake of scientific discoveries for the benefit of all patients. I want to close by expressing my thanks again to the administrative staff who helped plan this event, including Trish Meyer at IHPI, Noor Khan at the Department of Learning Health Sciences, and Veronica Williams at MISHAR. And I'm thankful to all of you who have come to North Campus and to all of those who have joined us online for helping us drive the future of clinical and translational science forward. So without further ado, I will turn it back over to Amy to help us start the program.
Thanks so much, Julie. And so I'm going to be here to set the stage for our two keynote speakers today and talk about the relationship between learning health science, learning health systems, and implementation science. And before I do so, I just want to acknowledge Gretchen Pyatt. Dr. Pyatt is unable to join us this morning. She is the Elizabeth Farron Professor of Learning Health Sciences and the Chair of the Department of Learning Health Sciences at U of M Medical School, and she's also Professor in the Department of Health Behavior and Health Equity at the UM School of Public Health as well. So I feel like I'm filling some really big shoes here talking which would have been a combined talk between the two of us, so you just get me at this stage. So I'm going to set the stage and talk a little bit about basically the relationship between learning health systems and implementation science and how they're catalysts and work together to enhance real-world health impacts. And so if there's like one message I would want to convey to the group today, it is this, basically that there are foundational sciences that make up a learning health system, which basically helps marry the research with quality improvement to get patients better. And those foundational sciences include implementation science. And in doing implementation science research, it's not scary. It's actually a lot of fun. And I'll say ultimately there is and will be money for implementation science going forward if you're interested in pursuing a career in this. So I just want to confidently say that, and I'm not just talking about my other hat I wear as a VA funder. So just going forward, I'm going to talk about a couple of objectives, and I want to be really quick because I feel like I'm, again, still the opening act to our wonderful speakers today. But I want to talk about differentiating implementation science and learning health systems and describing implementation science and how it functions with learning health systems as catalysts for real-world impact. So I'm going to give a broad, quick overview of these concepts so that we set the stage for our esteemed speakers later today who will be really doing more deep dives into these topics. But they're really basically, they're starting with two different starting points. So with implementation science, we're asking a question, how do we implement what we already works into real-world settings? In learning health systems is that how do we build the systems and capacity that continuously would generate and apply that knowledge? So think of essentially having the engine being the learning health systems and implementation science being the method by which you can sort of vector and convey that research into practice. Implementation science as a concept can stand alone, and what we mean by this is we have a lot of implementation science happening, and not necessarily in a learning health system format. It's a systematic study of methods and strategies used to integrate research findings and evidence-based practices into daily real-world settings. It aims to close that gap that Julie talked about earlier. The core features primarily are testing of implementation strategies, which are, think of these as organizational level or provider level interventions to change provider behavior. And in the situations where we cannot hire more providers, we have to basically work with our existing providers and empower them to adopt new things. And it can occur in a single clinic or a health system, or in also other settings like global health systems and things like that. It doesn't require what we consider a fully mature learning infrastructure, like essentially the underlying technology, data, people, and processes, although as you will find out, it actually helps a lot. So why implementation science can stand alone is basically it is usually funded through grants to actually support what we consider new knowledge about what implementation strategies work the best. You can also use the time in terms of your current funding to look at identifying barriers to implementation. And basically, it's a methodology that you can use in different settings. We've seen implementation science research happen when we have paper and pencil chart information, for example, not even EHRs. We've had implementation science happen in a setting, in a leadership setting that, at the time did not include other stakeholder input and probably should and could have. So basically, it's a science that stands alone, but it's actually enhanced when combined with learning health systems, because I think of learning health systems as having core sciences that support the growing and maturity of learning health systems. So learning health system is basically from the Institute of National Academy of Medicine is defined as when science, informatics, incentives, and culture are aligned for continuous improvement and innovation with best practices that seamlessly embed in the care process, and basically with patients and families, their caregivers are active participants in all the elements, and new knowledge is captured as an integral byproduct of the care experience. So the idea is that you provide care and you basically capture data so that you can learn from it over time. It's a repeatable, continuous, cyclical process. And the core features include learning cycles. If you think about Plan, Do, Study, Act as sort of a foundational type of cycle, it's also the integration of the sciences I consider to be foundational to health systems research, or just in general systems research, implementation science, the science of community and patient engagement, data science, informatics, system science, the science around operations research, and policy science or policy analysis. So these are core sciences that really form the foundation of learning health systems. And the idea is that these sciences don't act alone, but they really act in combination with patients as partners, with frontline providers as partners, as key stakeholders are involved in all echelons of the health system, jobs, and things like that. And it's also just not a single project, but it's an ongoing building of the capabilities. So you're not having a data set here, a data set there. You just basically continue using foundational data that could be used for different clinical trials, different types of studies, and so forth. So why learning health systems need implementation science? Because generating insights doesn't mean you automatically change practice. We kind of know that from just the literature here, but it's also basically learning would stall without having new knowledge about how to change provider and organizational behavior when you have these discoveries and you want to be able to change the practice. The other thing, too, is that implementation science is also foundational to learning health systems, because implementation science basically is a science that determines what quality improvement methods are working and what quality improvement methods could be generalizable and sustainable in future studies. So it basically feeds off that cycle by studying what essentially a quality improvement method that could be generalizable, and then basically applying that quality improvement method in future ways in which we improve the process and improve the care as part of the learning health system cycle. So this is just a schema that we've borrowed a lot from Dr. Friedman here, who's here in the audience as well. If you want to talk to him more about this, this is a wonderful way of being able to show the different components of the learning health system cycle and the formation of a learning community. That's really the different stakeholders involved in making the healthcare system work for patients, and having that opportunity to look at your existing data, capture what's going on, what needs to be improved in a clinical practice, understanding and analyzing those data and involving external evidence to figure out what are the best practices we ought to be basically promulgating in the system, and then also being able to design interventions and implementation strategies to make sure those practices then are applied in routine clinical care. So it's this idea of not just starting with a study and you have a data set and you're done, but being able to do that over time. The other thing I just want to talk about too is how the learning health systems can unite the research clinical enterprise. And I say that in part because that many times as researchers, our incentives are to get grants. And as health systems providers, our incentives are to get patients better and to basically improve quality. There's ways in which you can have your cake and eat it too and do both. And that's through learning health systems, and it's through the use of implementation science. But in doing so, it's being able to distinguish clear lanes of effort of implementation science and quality improvement, what's research, what's action in terms of quality improvement, and doing so in terms of, and we'll hear about pragmatic clinical trials later, that you can hear a lot about some of these subtleties of doing that. It's also the idea of utilizing and depending on EHR data for your clinical outcomes and clinical research. And again, easier said than done. If you're in a highly resourced place, that's great. If not, that's also a challenge, and you'll hear more about how to do that as well. It's also being able to do platform cohort and clinical trial studies based on the data lake or the foundational data from the EHR that's been enriched and curated. And then implementation trials that validate organizational change strategies. Again, you have a hypothesis that certain provider incentives or maybe precision audit and feedback or maybe ways of providing consultation or AI tools to frontline providers can basically improve the quality of care for patients because they help providers do the right thing. And their providers are busy enough and they can use all the help they can get. So when defining implementation science, I'll just kind of throw out a few more of these definitions and really go on to our keynotes here. But we wanted to just basically review what Jeff Curran had really eloquently described as what implementation science can do for you. And this was basically, he's done a lot of pioneering papers on study designs for different implementation studies. But we think of the intervention, the treatment as the thing. We think of effectiveness research looking at whether or not the thing works or not in patients, for example. Implementation research looks at how best to help people and places do the thing. Implementation strategies are the stuff we do to try to help people and places like frontline providers do the thing. And then finally, the main implementation outcomes are how much and how well we do the thing. So basically, it's doing a clinical trial, but doing an organizational trial at that higher level. And your unit of randomization often are providers or clinics, and your outcomes are utilization usually. So impactful implementation science requires learning health systems because basically to help us do more rapid clinical trials and make the findings reproducible and generalizable. There's also opportunity for embedded research opportunities. Clinical trials are getting more and more expensive to do standalone. We really need to think about ways to make them more efficient and more effective and more generalizable. And they also focus on solution-oriented issues. So imagine you're a health system executive, and you might say, that's great and wonderful, you have all these effective treatments, how do I get these implemented? The idea of implementation science is to determine what strategies are the most efficient ways of getting these implemented and sustained once the researchers go away. So I'll just kind of quickly go over a couple more references and then really turn it over to our speakers here. But basically, we had published a paper that focuses on implementation science and learning health systems as part of an expanded version of the learning health cycle called the Translation to Policy Learning Cycle, where we really thought about embedding implementation science as part of the people, which are the learning communities, the processes, thinking of implementation strategies, and then the policies of having research and QI lanes of effort, and then the technologies having the ability to curate data from different sources, including digital health. And the idea here was to build a learning cycle that would have applied ways of actually how to do this type of research at each stage of the cycle. So like performance to data, which is where we start with the learning health system cycle, is having the learning community get together, identify, and using user-centered design, think about ways of essentially identifying opportunities to tailor an intervention or treatment, and then identify the implementation strategies to test and the outcomes of interest. Data to knowledge is basically conducting cohort studies, for example, to identify determinants of gaps in quality and identify effective practices, and also understanding why the gaps exist using mixed methods. And the knowledge to performance would be to apply implementation strategies to maybe test them, to spread effective practices, see what works and what doesn't, especially with sustainment as well. So I finally just want to end, and again, I want to just put these out here as things I just grabbed from the internet, and those include the NIH reference to funding priorities, their strategic goals, as well as highlighted topics. And I put this out here in part because I think, there's been a lot of change since we last saw each other back last November, and a lot of things happening. And I know a lot of uncertainty and anxiety about essentially funding and things like that. But as a funder myself, and also someone who had majored in rhetoric as an undergraduate student at Berkeley, I always look for what people are saying and try to emulate what they're saying back. And in terms of what they're saying, in terms of the priorities, I'm hearing essentially replication, reproducibility, real world data, artificial intelligence, promoting research focused on scientifically valid measured health outcomes, and surprisingly, areas like shifting to solution-oriented approaches to health disparities research. That screams learning health systems and implementation science, in my view. And in the latest look at the NIH highlighted topics, basically implementation science is well represented in several of these topics. So again, if you look at these ways in which NIH is articulating what their priorities are, the hope is that in the future that it basically will afford you an opportunity to really make your persuasive case in your grant applications that, hey, this is really cool research and basically it needs to continue.